ten Ogles, který je profesorem klinické psychologie, působí na Brigham Young University v Utahu. A kromě toho působil v minulosti také na Ohio University, na obou těchto univerzitách působil mimo jiné jako děkan. Je autorem 2 knih a množství odborných článků a kapitol, které se zabývají měřením terapeutické změny a výzkumem psychoterapie, zabýval se společnými účinnými faktory, zabýval se motivačními rozhovory, také etikou. To je takový největší paradox toho našeho sympozia, protože Ben pochází z největší dálky a přitom právě teď sedí za mnou, můžete ho vidět 2krát. Takže, Bene, předávám ti slovo.
I'm very grateful to Dr. Zhachik and Dr. Vibiral and Dr. Lasanova, who've invited me here. My wife and I have been enjoying the Czech Republic very much for the last 10 days and look forward to a few more days while we work on projects and enjoy Masaryk University. Today, I'm going to talk about clinical significance. So my focus will be more on the end of treatment. And that is, how do we know if someone you've been tracking with change on, you've been using routine outcome monitoring to track their change over time? How do we know if the changes they've made are meaningful? And I'm going to use quite a bit of research material and show how clinicians can use that. I've included more detail in the slides than is necessary for those who are interested in the research. And so I will go quickly through it, but since it's being recorded, for those who have that interest, they can go back to the recordings and see that detail. So let's get started. And just an overview, I'm going to give a little bit of history. I'll talk about some methods and definitions for defining clinical significance. Then I'll talk about several potential problems with those methods and make some conclusions and recommendations, all with the focus of helping clinicians to think of some ways that they can determine whether their clients have made clinically meaningful changes in addition to statistically meaningful changes. Even early in the psychotherapy research, people were thinking about, in the quantitative psychotherapy research, people were thinking about clinical significance. So for example, this quote from the report of the Berlin Psychoanalytic Institute: "We were most particular in what was to be understood as cured. Included were only such cases where success meant not merely the disappearance of symptoms, but also the manifestation of analytically acceptable personality changes, and wherever possible, confirmative follow-up." Of course, these decisions about what was cured were made by the therapists or by therapists rating the notes of other therapists. So there may be some question as to whether they understood every perspective on that change. But the point is that even early in the history of psychotherapy research, people were thinking about, what does it mean to be cured? What does it mean to be meaningfully clinically changed? In the early primary research, we focused mostly on statistical significance. There was pressure to prove that psychotherapy was effective, and we needed to do that in a scientific way using control groups, and also with statistical tests to be a science. And the ultimate finding was that both in terms of effect sizes and statistical significance, that treatment is effective compared to control on average. The problem with that, when you look at that average change, is that it doesn't tell you about the size of the change. It could be statistically significant, but not clinically meaningful. Or it could be statistically significant, but not important. Or maybe the size of the change is very slight. On this graph here, I show the Beck Depression Inventory. The average for clients entering treatment for depression on the Beck Depression Inventory in studies of psychotherapy is around 22. And the average afterwards is just below 10. Is that a clinically meaningful change? Is a change of that many points on a scale meaningful? That's the question that we're going to talk about today. So here are some of the methods and definitions for determining if one has made clinically meaningful change in the research literature. And I'll suggest some ways that these might be applied in your clinical practice, especially while you're tracking change already with some routine outcome monitoring system. The first set have to do with improvement-oriented methods. The second set have to do with recovery-oriented methods. And then there's the Jacob and Truax method, which is the most commonly used, that combines those approaches. I'll talk about each in turn. First is the reliable change index. And this reliable change index is really, it may look more complicated than it is. You take your pre-treatment score on a measure and subtract it from the end of treatment score on a measure, say the outcome questionnaire 45 or the Beck Depression Inventory or an anxiety measure, and then divide it by the standard error of the difference between those two test scores. The point is for clinicians that once you know the RCI, the reliable change index, for the measure you typically use to track change and the population you serve, you can always use that number. So for example, the outcome questionnaire 45 in most outpatient samples, in the United States at least, a change score of 14 points can be considered reliable improvement. That is, it's not an improvement that is probably the result of random fluctuations in the scores by the client. It's more likely to be a reliable improvement. Of course, a decrease of 14 points or an increase in symptoms of 14 points would also be reliable deterioration. But the idea is, as a clinician, once you have your measure and know what the reliable change index score is, you can use that at any point to determine if your client has made a reliable improvement or a reliable deterioration. In the research literature, there have been a number of proposals about how to modify that using different formulas. Those are not so important, primarily because the Jacobson-Truax method is still the most frequently used, even though some people experiment with these other formulas where they argue about the statistics to be used. So for a clinician, I would suggest that the main thing to think about is, what is that number that you can use to determine whether your client has made a reliable improvement? Now, as I say that, what I'm also suggesting is that in your documentation of a case, so for example, when someone finishes therapy and you're writing up your post-treatment case note about the person, if you're using routine outcome monitoring, you can also say, and they made a change of 17 points on the outcome questionnaire, which is indicative of a reliable improvement on this outcome measure when considering symptoms. So it's a way to improve your documentation for therapy. Our second method for looking at improvement, so that is, are changes moving in significantly clinically meaningful, is the percent improvement method. This was historically used most frequently in health psychology. So for example, this headache index used by Blanchard and Schwartz in the headache treatment literature. And what they suggested is if you took the headache index, which was an index of the frequency of headaches and the intensity of headaches, so the combination of frequency and intensity, and you calculated a percent improvement, if it was 50% improved, then they would call that improved and clinically significant. If it was an improvement of 25 to 49%, then it was only slightly improved. And if it was improved less than 25%, they would say that the person did not improve. And you can see that Lentz in 2020 is still suggesting that for some cases, a percent improvement method of determining if someone has made progress can be used. If your particular population and your clientele fits this kind of assessment, then this may be a way you can routinely assess for clinically meaningful change and determine what percent improvement, for example, in eating disorders or in headaches or in compliance with diabetes or asthma treatments would be warranted as a clinically meaningful improvement in their functioning. Another similar sort of rating is called the minimally important difference. And this evolves from the early perceptual literature of the just noticeable difference. And the idea being that if you make a big enough change, then it is different enough that it alters the way you conceptualize the case. I have here a historical example from Michelson, where they had a priori cutoff points on self-report, judge-rated, and therapist-rated, and the behavioral approach measures for agoraphobia. So if they moved a certain amount on those, then they would considered it an important difference. Here's a more modern example of this, a study in 2007. And this involved the profile of mood states, depression measure, and the profile of mood states, total mood. You can see in the table that they calculated it 3 different times, thinking about what would be a minimally important difference. Is it 0.2 standard deviations? Is it 0.5 standard deviations? Or is it 1 standard error of measurement? And depending on which one you pick, you get more people that that had major depression and received supportive expressive group therapy that had achieved that cutoff of minimally important difference. So one way to do that, so a way to do this in clinical practice then would be to take your measure and determine what cutoff would be sufficient for you to say, this changes the way I conceptualize the case. If they started with a Beck Depression Inventory of 30, at what level would be a difference that was important enough to change the way I conceptualize it? Then you can establish that and use that as the way you determine whether someone's made clinically meaningful changes. So far we've looked at the reliable change index. We've looked at percent improvement, and now minimally important difference, all as ways of looking at, is the change big enough that you think of it as clinically meaningful in that way? Okay, another completely different way of thinking about clinical significance is to look at it as recovery. So instead of taking a look at, is the amount of change big enough to be considered meaningful? Now we're going to look at the end of therapy, is their status at the end of therapy sufficient that we should consider it to be a meaningful change? So here, we're going to look at 4 strategies. One is diagnosis, one is end state functioning, one social validity, and one is normative comparisons. We'll do that very quickly. So the first one is diagnosis, and this is very straightforward. You do a diagnostic interview at the beginning of therapy, and you do a diagnostic interview at the end of therapy, and presumably they meet the diagnostic criteria at the beginning, and they don't meet the diagnostic criteria at the end of therapy because they've improved. And this way you've demonstrated that they've made a clinically meaningful change by diagnosis and non-diagnosis at the end. And here are 2 studies that use this strategy for assessing, one in a childhood study and one in an alcohol use disorder study. And in both cases, they suggest that it was effective. Another way to do this is with end state functioning. This is very similar to the minimally important difference. And essentially what you do is you establish a cutoff at the end of treatment, and you say, if they go below this, then you're going to say they have a high or good end state functioning. Michelson did this for the treatment of agoraphobia. They established a priori criteria on several measures. And if you met those criteria, you added them up, and you could have high end state functioning, medium end state functioning, or low end state functioning, depending on those 4 measures and whether they met those criteria. A more modern example is this one from Litz in an internet-based therapy. And they decided that a Beck Depression Inventory 2 and a Beck Anxiety Inventory score less than 12 and a PTA PSD, a post-traumatic stress disorder symptom scale, an interview version less than 6 would qualify for high end state functioning. In their particular study, their self-management for cognitive behavior therapy had 29% that met that end state functioning, while the supportive counseling had 0% that met that criteria for end state functioning. So in this case, then we're talking about two other ways for determining whether someone made clinically meaningful change. On the recovery side, one is whether they have the diagnosis before and not after. The second is we determine some criteria for what's high end state functioning on our measures, say below 12 on the Beck Depression Inventory. And if they meet that, then we say that's meaningful change. Another way is through social validity. This typically involves, it's more of a research type thing, but we ask people. So for example, the social comparison or subjective evaluation, we have people rate whether someone's behavior before and after treatment has improved. For example, the subjective evaluation, they actually had police interact with juvenile delinquents before and after treatment, and then they had people rate them to see if the teenagers were more cooperative and polite in their interactions with police officers after the intervention. This is often applied in behavioral analysis, and it's often used with scales and questionnaires. And if you want to pursue that, then you can find some of those questionnaires in order to determine that the changes are socially meaningful to those around the person and to themselves. And then finally, there's the normative comparison. So we can establish normative distributions for a measure. And we can say, okay, this is what people in the normal population look like. These are what people that attend treatment look like. And movement from one distribution to the other distribution then is classified as clinically meaningful. I'll show this in the next slide where we talk about improvement and recovery and with the Jacobson and Truax, where we're combining now the ideas of improvement and recovery. So you see the graph there, the functional distribution might have an average score of 60 on a measure, while the dysfunctional has an average score of 40. And the idea is you move from one into the other. And you can define your cutoffs in different ways, but you find a point at which you decide that you've now moved into the functional distribution. So for example, on the outcome questionnaire 45, that cutoff is 64. If you have 64 and above, you're considered part of the distressed population. If you have 63 and below, you're part of the normal distribution. Okay, so I've talked about 4 ways of looking at end state functioning, the way it is at the end of treatment. And I've talked about a few ways of looking at change and whether it's big enough. And Jacobson and Truax combine these. So their idea is that you have to have a big enough improvement, so 14 points on the OQ45, and you have to move below the cutoff point. That would be 64, below that 64, so 63 or below. If you make 14 points of change and you're below 63 or below, then they consider that to be clinically significant. All right, those are the different ways that you can, the definitions and methods. Now I'm going to talk about a few of the problems with these and ways that people are now working on improving them. But you get the point. As a clinician, you could use any of these methods. You could decide I'm going to do the diagnostic interview before and after. I could decide that a 14-point change is a reliable improvement. I could pick a size of change that is minimally important for changing the way I conceive of the case. Or I could think about a certain amount of improvement in percent improvement is necessary for change. Or I could think about it from the end of treatment point of view. If they move into the normal population, if their end state functioning meets these criteria on the measure, then I'm going to think about it as clinically meaningful change. So all those could be applied in clinical practice, especially if you're using some sort of routine outcome monitoring system And some of them will calculate this for you automatically. Here's a graphic representation of the Jacobson and Truax method. So the double green lines going up at the diagonal, anyone in between those, so like person A, would say is no change. And that red line on the diagonal is the line of no change. Their pre-treatment score is the same as their post-treatment score. If they're outside the band of the green lines, so then it would be either below the line would be reliable improvement, or above the line would be reliable deterioration. And then we have a cutoff there. In this case, it's 42. It's a different measure. It's the Ohio scales. If they're below that line, then it counts as clinically meaningful change. It's now in the functional range. So then you have all three. So this is a nice way to display that if you want to display it. And I've seen clinicians actually that will put everyone that, or at a clinic, for example, everyone that received treatment for depression, or everyone from an eating disorder clinic, and they plot them on this in order to track how their clients are doing in this sort of format. Okay, so now some of the problems. One of the problems is that it depends on what parameters you choose, what your reliable change index is. You don't need to get caught up in the details of this. These are all special populations on the Beck Depression Inventory. And you can see that depending on which group you use as your normative comparison group, the RCI could range from as high as 16 to as low as 5. And the cutoff score could be as high as 27 and as low as 9. So one of the things that you need to be careful about is what population you're comparing to and what population you're treating. This non-distressed group, for example, here, it was selected specifically because they had no symptoms at all, which is not very much like the general population. There are people that just have no symptoms. So one problem is choosing the parameters. But it doesn't matter so much for clinicians as long as you pick your measure and your population to compare with up front. And then you know that 14 points change is going to be just fine. And your cutoff of 63 is going to be just fine. And you go from there. But if you have a specialized population, you may want to work to figure out exactly what the cutoff is, both for the amount of change and for moving into the normal population. Another concern is the problems of validity. Are reliable changes really noticeable? Are scores in the normal range really, is it the client's experience that they've had meaningful change just because we statistically define 14 points? Are changes on one measure concordant with another measure? What if I give the Beck Depression Inventory and the outcome questionnaire and one shows reliable change and one doesn't? These issues of validity continue to plague us, and there have been a number of studies to try and solve that problem. For example, historically, there have been a couple of studies that looked at this. In one, therapists were quite good at being in agreement with clients who changed retrospectively, therapists rating retrospectively, but they didn't do very well in distinguishing between clients who deteriorated and clients who didn't make any change. And there's a recent study where they looked at the clinical global impressions by independent raters with the Jacobson and Truax method, and it was correlated. So there is some evidence that a 14-point change, for example, is meaningful in the lives of clients and by observers. This is from the NIMH depression study. That the busyness of don't let the busyness of this fool you. This is just looking at whether across treatment groups and different measures of the Beck of depression, whether there's concordance. So the Beck Depression Inventory, Hamilton Rating Scale, Hopkins Symptom Checklist were the three measures. And then the CBT, interpersonal therapy, imipramine, and placebo were the four treatments. And you can see that there's a fair amount of agreement. All three of the measures found that people made significant change or didn't make significant change with the top line and the bottom line. And there was only some, so there's quite good concordance, 75% concordance, at least in this study, among the three measures, even across all the treatment groups. Some of the problems of the and limits of assessing clinical significance using global symptom measures have been studied recently in mixed method studies. And I'll not cover these in great detail. Let me just say that this study, of course, conducted here at Maastricht University, showed that there's some discrepancy between clinical significance measured prospectively and interviews. And they suggest that interviews might be a nice complement to routine outcome measurement. In this study, they studied specifically people who recovered or improved based on that reliable change index, and then compared that with qualitative analysis. And they found that people, even who were recovered, sometimes said that that change was an ongoing process, that they still had unresolved and recurring issues, even though their symptoms had improved greatly. Similarly, in this study, they used qualitative research to look at 29 individuals who made changes in both directions, and they found differences, and they even said remarkable differences between some of these cases, between what the symptom measure said and what the client said after. We did a similar case study. We identified 22 people and selected one who said that his therapy was successful, even though using the outcome measure, he deteriorated. So here's a look at his graph. He completed 5 sessions of therapy, and you can see that from the first session until the last session, he got worse. This was the outcome questionnaire. So he went from 40 above the clinical cutoff, above 63. And then the therapy was mutually terminated at session 5. The therapist used the outcome measure in the sessions or discussed the progress. So he even discussed the fact that the client had increased in his symptoms and still terminated the case because he felt comfortable that the client had made improvements. And then the final X down there is when I interviewed him later as part of this case study, which was several months later. And I won't present all the results here, but here's some examples of his statements, the client's statements about how he gained insight. So he realized that he was alone. And he realized that he needed skills to help his mental health. He also had insight about accepting his limitations and recognizing that because you fail, that you can still succeed later. And he realized that part of his stress was related to not being prepared to enter college. And then he gained some skills about being a passive observer about what was going on in his mind, that he didn't have to always fight his thoughts, sort of an ACT kind of treatment. These are just some examples of the way in which he changed. There are several others in terms of his social life and in terms of the relationship with the therapist. I picked just this one section on insight. And here's what he said about the discrepancy between his report that I benefited from therapy and the symptom measure saying he didn't benefit from therapy. He said, first he said he thought he was more aware of his symptoms. In fact, he thought maybe that he could have been denying some symptoms when he first took the outcome measure at the beginning of treatment. So maybe his responsiveness to the outcome measure changed over time. He thought he had a greater capacity to manage his symptoms, even though those symptoms were there, because he had some skills that he didn't have at the beginning. He felt like his attitude towards those symptoms also changed, that he had a growth mindset, that they weren't catastrophic, that he could have symptoms and still be able to function and do well. And finally, he said that his spirituality improved and that the measure didn't have any items that reflected that change in his spirituality over the part of treatment. So the main idea of this study, this case study, and those 3 previous mixed method studies is that even though you may be using routine outcome measurement, it may be helpful to supplement that with some other qualitative approaches. In the Robal study, they suggest some structured interviews given periodically during treatment. In other ways, it may be like this therapist in this particular case, because he was presenting them the prospective measurement results to the client every session and talking about them, he was well aware of the way in which he felt like he had progressed, even though it suggested that he was declining. Now, I might add that this can also work in reverse, right? Someone that could appear to be progressing on the outcome measures may have some ways in which they still need to progress. And so having that qualitative data in addition to routine outcome monitoring can be quite helpful. Okay, I think I'll skip this last section. This is really much more technical. And the idea is that we have statistical methods now that can look at the way someone answers the questions on a measure and weight them differently for each individual. And this is really appealing because then we're using a standardized measure, but treating it uniquely. For example, if a person with post-traumatic stress disorder takes a questionnaire, one might have flashbacks and one may not have flashbacks. And so for the person that does have flashbacks, we should weight that item more heavily in thinking about their outcome than for the person that doesn't have flashbacks. And so intuitively, it fits the way clinicians think about it. And statistically, we're now sophisticated enough that we can start to weight items in that way so we get unique profiles. I have several slides that illustrate this, previous studies, and then our own study. So for example, these are the items of the OQ 45, and you can, what you need to know here is that if you're female, or if your distress category, your age, or your religion, or your minority status or international status are calculated, it changes the way these items function. And so that allows us to more uniquely tailor your responses to who you are. This also shows the distribution for this group of 5,500 clients in terms of how many deteriorated, no change, or improved, and how many were below the cutoff. Interestingly, it's very similar to the numbers that Jamie and Kim talked about yesterday, with about 9% deterioration, 60% no change, and then about 30% if you combine the reliable change and clinically significant change together, which is slightly lower than their number, of which I think was 35, 36%. Okay, that's enough. I won't go into more detail about that. I will say that we need more research about these dependent variables so that we can have be more convinced of their validity. And these parameters matter, and a continuing work on the qualitative side of this with interviews will be helpful. But you now have a few strategies that you can use to determine at the end of treatment whether someone's made clinically meaningful change using a number of strategies from research methods. Those include things like the reliable change index. Is that number big enough that we consider it reliable, or percent improvement? Is the end state at a place that we consider them more like those who don't need treatment than those who do need treatment, by their diagnosis, by their score in the normative range, or those other methods, or by combining them in the Jacobson and Truex method. And then we'll continue to do work on this that will allow us to have better ways of helping clinicians know when someone's made a clinically meaningful change. I included all the references here for those who want to know about them. Thank you. Dakuyi.